at Kaiser Permanente in Downey, California, and I'm the regional lead for the Southern California Permanente Medical Group Child Abuse Prevention Program. And through that, we got interested in looking at ACEs, adverse childhood experiences, and screening for them in some of our pediatric clinics, and so that's what we're going to talk about today. And I do have my partner, Dr. Lisa Ishilian-Oates here, who helped us sort of plan all this. So, okay, just briefly, we're just going to go over the background and then the planning and implementation and spread of our project, and then we'll go over some of the data towards the end and some of our learnings from it. So the background, we initially just wanted to show that screening for ACEs is feasible in primary care pediatrics and, in fact, in larger group settings like Southern California Permanente Group. We have 15 medical centers, and each spread throughout the Southern California region, and each medical center has several pediatric clinics employing hundreds of pediatricians, and we cover 1.5 million children in Southern California. So big scope, and we wanted to see if we could implement a screening program covering those kids and how could we make it work in such a big practice. None of the studies published about ACEs thus far have been that big in scope. And then we wanted to help understand the expected prevalence rates to allow providers to plan for additional resources that they might need once we start addressing ACEs more, particularly in California. The planning took about 18 months in total before we actually started the screening process. It required a lot of integration between our regional leaders and our local support teams, which I'll get into in a little bit. And we also worked closely with the National Pediatric Practice Community on ACEs, which is a group within the Center for Youth Wellness, which if you're familiar enough with ACEs, you know Nadine Burke-Harris founded that group up in Northern California. And the MPPC group really facilitated, they gave us all the materials we would need, the screenings, the information that we could share with parents. They helped us, they actually flew down from Northern California and met with us a couple different times and worked with my local department administrators and nursing team and social medicine to help us set up a workflow that would work. And they helped us define our data parameters and how we were going to collect the data and evaluate it. So they were very instrumental in helping us put this together. I truly couldn't have done it without them. And then internally within SCPMG, we had to coordinate our electronic health record teams. We had to get our pediatric chiefs on board from each of the medical center and in the region. We needed clinical leads, including our department administrators, our social medicine team locally and regionally, our nursing staff, our receptionists, everybody. We had to form kind of local groups to get everybody on board. And then community resources, we had to try and partner with some or find some community resources because internally to SCPMG we didn't have a lot of referral for trauma-informed care yet. And we do have behavioral health and counseling and therapy, but not every kid with ACEs needs that. So we worked on some community resources. And then our data scientists, we initially worked with our local medical center data scientists, and then as we expanded this, we worked with our regional data scientists to pull together our numbers and look at them because that is not my specialty at all. And all of these people coming together, the meeting of the minds created this workflow that I'll show you. We did multiple revisions. Each group that we talked to had suggestions. The questionnaire selection, the choices of ages that we looked at, the documentation. We had to create diagnosis codes. So there was a lot of background work that went into this before we were able to release it and start using it. This is a questionnaire we chose. It's the original 10 ACEs questions. And when we first started this project, I was very pie in the sky, lofty. I wanted to screen every pediatric patient at every pediatric clinic at SCPMG. And I wanted to use something like the PEARLS screener, which is these 10 questions plus an additional 5 to 10 questions on social determinants of health. And we worked closely with our pediatric domain team who oversees our electronic record and usage and talked with our pediatric chiefs And people initially were very anxious about the time commitment this was going to require of pediatricians, and the workload that it was going to involve. We narrowed it down and agreed to just use the initial 10 ACEs questions as one of our compromises. So that was what we started with. And we chose to use it in a de-identified fashion because through the Center for Youth Wellness MPPC group, they had found some research better results in using a de-identified screener, and found that patients were more forthcoming and honest with their answers if it was de-identified. And I'll show you how we work that into the workflow as well. This is really tiny, but this PowerPoint is going to be really easy for you to look at. This is our workflow, and like I said, there's many iterations. This is actually not even the most recent. This is as about 4 months ago when I started putting this slide show together. But I'll go over it. Basically what happens is we are screening now at ages 3, 5, 10, and 13 at their well child visits. And we chose those ages because when we first started, we chose only 3 and 5. And the reason we chose those is because they were the easier visits for pediatricians. There's no other developmental screening. There's no shots at those visits typically. And when we have a well child, 3-year-old or 5-year-old, it's honestly probably our easiest clinic visit of all the kids we see. It's a little 3-year-old, little 5-year-old, and there's nothing extra. So when we worked with our domain team and the pediatric chiefs and the social medicine team and everybody, our agreement was to start with ages 3 and 5 because those were the easiest ages to slide in a new screener. And then later, I'll get into, we expanded to ages 10 and 13 for similar reasons. So our receptionist hands out the questionnaire at when they check in for their well child visit, and they get their regular pediatric 2-page questionnaire for healthy children, and then they also get the ACEs questionnaire handed to them as well. The patient or the parents for the 3, 5, and 10-year-olds fill it out in the waiting room. The 13-year-old fills it out on their own because they're a teenager and it's private. And then when the MA or LVN takes the patient back to get checked in and vitaled, they then take the questionnaire and they take the number from the de-identified screen and enter it into our Health Connect computer system. And they just enter the numerical value. And then they also put on the chief complaint for the physician to see, they have a phrase they can just type in a little dot ACEs, and it pops up for them and it says results review ACEs blank, and then they'll enter the score. So as soon as the physician opens the chart to review before they go see the patient, immediately right on the top of the page it says results review ACEs score blank. So the physician knows before they walk in the room what they're getting into. If the score is 0, I think there's a dot here. I'll just go here. If the score is 0, the only thing the physician has to do, if they choose to, is print off a patient information sheet that we created for this that explains what ACEs are and has some resources at the bottom. And the resources are very generic because it had to span across our 15 medical centers for all of Southern California, so we couldn't have like an LA specific resource or a San Diego specific resource. We just kept it pretty broad. And if the score is 0 and the patient's doing well, we don't even require the physician to really explain anything unless the family asks what the screener was. If the score is 1 or higher, we ask them to screen for safety. And what we've coached them with our trainings to do is just ask, I see you had a score of 2. Did you want to share with me what you answered yes to on the questionnaire today? And then, do you feel safe going home? Do you have any concerns? Would you like help with that? So it addresses some of the safety concerns that might come up with the ACEs screener. And then we screen for symptoms. And when I presented this to physicians, I like to always include and encourage that this is not extra work. This is what you do in your normal well child visit. You're screening for behavioral issues, sleep problems, eating problems, poor chronic disease control. This is not an additional workload burden for them to be looking for these problems. It's just that now you're doing it at this visit with a lens of ACEs on top. And in fact, I think that may even shave some time from the visit sometimes, because if you got a 3-year-old with speech delay or major behavioral issues and their score of ACEs is 7, you might have a reason why, right? So then we talk about screening. And then if the score was 1 to 3, but the child's doing fine, they don't have any symptoms, they're healthy and happy and thriving and growing, The physician, we provided scripting for them and just does a brief explanation of what ACEs are and why we're checking for them. Offers the family resources to either our social medicine team or behavioral health if they want it, even though the child's doing fine. Gives them our patient information sheet, and then uses our diagnosis code positive screening for adverse childhood events and puts that in the health record. If the score is a 4 or higher, or if it's a 1 to 3 with symptoms, then that's when we do a little more. We do all the stuff we do for 1 to 3 asymptomatic, but in addition, we actually place a referral to social medicine or behavioral health for follow-up, because these are the kids that are actually going to need, and the families who are going to need some intervention. So we do a more formal referral process for those kids. So implementation, this was many-fold. So first we had to think about training when we started this, and now a lot more people have heard of ACEs. When we started this a year and a half ago, pretty much nobody that we talked to had heard of ACEs, honestly. I mean, we all had, and we were kind of surprised nobody had heard of it, but people were very unfamiliar. So we incorporated just a training for our physicians and staff all together. We would have a lunchtime training. When I implemented it at the Bellflower office where I work, we just had a lunchtime meeting with all our physicians, receptionists, LVNs, MAs, our social worker in the clinic, everyone all together. And we trained them in ACEs science. What is it? Why does it impact our patients? Why does it impact you? And then we also incorporated the workflow that I showed you, and some resources for them as well as their patients, because obviously we want to be trauma informed when we present this, and we're sure to talk about resiliency and provide resources for the staff as well if they were feeling overwhelmed or upset after the presentation. Throughout the last year and a half, we have done some retraining. We had a couple meetings just to regroup, review the scripting and the workflow, and kind of reinforce. We shared some of the early data with the physicians and the staff so that they could see the work we were doing and some areas for improvement. And then we did develop at Bellflower only, not the other medical centers, a maintenance of certification project for the physicians where they reviewed their own data and could make self-improvements to improve their screening rates. When we implemented this, and in the prior things I talked about on the earlier slides, when we presented to the chiefs and the pediatric domain team and our own physicians in clinic and the staff, we saw 3 to 4 main concerns that routinely popped up over and over. One was a concern about abuse reporting. So there are 2 or 3 questions on the de-identified questionnaire that ask about abuse, and people were really, really concerned that if it was de-identified, how would we know if we had to report? And we don't want to just let these patients go back home without identifying that there was abuse in the home. And what we decided, we had a couple of different coverages. One was that on our well-child physical questionnaires, we ask 2 questions about abuse in the home. And if they say no to those questions, but they have an ACE score of 2, we felt that it was safe to make the assumption that the 2 questions on the ACE questionnaire were not abuse related, because they answered no on the other questionnaire. Whether or not that's true, but that's what the assumption was that we went with. The second was that the physician should be asking about in their workflow safety. So when we have a score of 1 or 2 or 5 or 10, the physician should be asking, are you safe to go home today? Can you talk to me about what the scores you said yes to were, and then if abuse comes up, then evaluating whether or not it's something that needs to be reported. And one of the things we talked about also was that just because someone says yes to abuse on the well-child questionnaire, I don't just go call DCFS. I go see the family first. Why did you put yes? What happened? Is this 5 years ago? Did this happen last week? You have to do some information gathering anyways. And the third was, if the score was an 8, a 9, or a 10, you could safely assume that one of the ones they said yes to was abuse, because there's 3 abuse questions. So if it's 8 or 9 or 10, then we really mandate that providers dig in and get into what are they saying yes to, or which of the 3 did they not say yes to, because that's obviously much more concerning. And to date, we actually haven't had any patients that have scored that high yet. So, but that addressed the abuse reporting. Time constraints, the physicians in particular, we're extremely worried about this. We have 15-minute well baby visits. The 13-year-olds get 30 minutes. And everyone was very worried that this workflow was really going to be an interruption and take a lot of time, and this counseling was going to take a while. And one of our reassurances was a smaller version of this workflow had been done in Northern California, Kaiser, and they had actually done a retrospective review afterwards. They had polled the physicians and the staff on how much of an intrusion into their daily clinic flow this work was, and I think it was like 98 or 99% of them felt that it was not intrusive at all. And so I was able to share that data as we rolled it out here to reassure people. And again, it doesn't add that much because the screener is done in the waiting room, the doctor can review it, and when I show you our data, it's not a huge percentage of these younger kids that are needing a lot of intervention, and the scripting we have takes about 1 to 2 minutes. So overall, it hasn't been a huge burden on the staff or the physicians to implement this. The referral process is something we're still working the kinks out with. Our social medicine team does have some local resources at each medical center that they can send patients to if they have a higher ACEs score. And then our behavioral health team does offer trauma-focused behavioral therapy, but our Kaiser process of getting into that is a little murky, so we're working on a better workflow still, considering just referring to social medicine now and having them triage the patients into either community resources or getting them a direct referral into our behavioral health clinics to help facilitate a little better patient follow-up for that. And then the general comfort level in discussing this with patients, what we found is providing scripting for the providers and the staff and the receptionist helps. Just literally just telling them how to talk to patients about this, and then having our follow-up meetings to go over it. I sent out reminder emails every couple of months. Hey, remember, this is the scripting you can use. This is what you can talk to your patients. And the other thing I did was send out and share anecdotal stories of patients I had seen or that other providers had told me about to show the impact and how we talk to those families about ACEs and what we were actually seeing in clinic. And I think having those anecdotal stories help people kind of get a little more comfortable with how to talk to their own patients about it. Our spread, so initially we started at the clinic I'm at in Bellflower. It has 25 pediatricians, and when we kind of worked out the kinks of our workflow, we then spread it to 3 other medical centers, which included 5 clinics total. And the way we did that was sort of, I like to say it's like franchising. So I went to my child abuse prevention program group, and each medical center has physician champions for the child abuse program. And I went to our big group and I said, does anyone here want to try and do this pilot with me? Does anyone here? And the people who volunteered are in the room right now. They raised their hands, and there's 3 of them. And I said, yay! And so, thank you. And they volunteered, and so what we did was a train the trainer. I gave them all the materials we had created for Bellflower. We had a phone call, a teleconference where we went over virtually the PowerPoint that we had created, the workflow, everything, and then they took all those materials and taught, just like I did at a lunchtime lecture, taught their clinicians and staff the same information, the same workflow, the same training, so that it was standardized across the region at these medical centers. And in the past year, as we've moved forward, other people have come forward and reached out with interest in participating. So we've actually added on 3 more medical centers, which is now we're at 9 clinics total. It's about a third of our population. And then because of the new Medi-Cal ACEs Aware initiative that's happening in California, we are actually now in some very complicated processes of trying to expand what we've done with our pilot across the entire region to all of our pediatric clinics. And that is a bigger hurdle, but I'm glad we did this pilot first because we have a little bit of a foundation to step on. So the coordination of champions is what I just talked to. Workflow, so the workflow I showed you is nicely adjustable to each clinic. So there's a standard workflow, but we had a couple clinics, particularly West LA and then Antelope Valley, who their reception is not just for pediatrics. They check in everybody from 0 to 100. And their receptionists were very uncomfortable remembering to give the ACEs questionnaire just to 3 and 5 and 10 and 13-year-olds because they have so many adults checking in as well. So what those 2 clinics decided to do was actually have the MAs and LVNs give out the ACE questionnaire, And as you'll see, I think that reflects actually in our data a little bit. They had a little bit of higher positive and a little bit of higher, the ACE scores themselves were a little bit higher. So I don't know, we haven't delved into the science behind that. I don't know if maybe having the MAs or LVNs go over the questionnaire with the patients actually garners better results or not. But it was just interesting to see that variation. And then, like I said, we added on ages 10 and 13 as we progressed as well. So our results, this is what our data people are doing, so I'm going to read this, but please don't ask me questions. So the analysis was primarily descriptive. We used number and percent of those screened, which I'll show you. And then we looked at those with one or more ACEs to tabulate our data a little more. And we did it by age group and medical center. So we had it by medical center, but we also had it by ages 3, 5, 10, and 13. And then this is the part they used crosstabs and chi-square tests to examine significant differences in the proportions between age groups for those with 0 versus 1 or more ACE. So our results. So since July 2018, so it's been about a year and a half that we've been doing this work, we have screened, and this is data as